Are we live? Are we live? Hello. Okay. So now we're gonna quickly revise brainstem syndromes because it's very important for NEET PG exams apparently. So how it's gonna? I'm a mess. I'm a mess. I'm a mess. How we're gonna revise it is basically I'm gonna write everything so that you don't have to listen to my ugly voice. So brain stem syndromes. I'm gonna make it quick. So there are basically 4 plus 3 plus 2. This is very important. So basically there are total 9 brain stem syndrome, 4 in midbrain, 3 in pons and 2 in medulla. Okay, so we're gonna start with obviously midbrain. We're gonna start with midbrain. Now obviously there are midbrain may also at the level of superior colliculus, inferior colliculus you take a section, but we're not gonna do that. We're gonna do what is important for the exams. So midbrain, we take a section over here and we draw it. Now I'm drawing substantia nigra compacta. This is affected in this thing, Parkinsonism. So normally we see a swallowtail sign, which we don't see in Parkinsonism. There is hypopigmentation. So you know what is peduncles, right? The peduncles is the one which connect the cerebellum to the brainstem. So you know the superior cerebellum superior cerebral peduncle connects the superior part of the cerebellum to the midbrain. The middle cerebral peduncle connects the pons to the cerebellum, and the inferior cerebral peduncle connects the cerebellum to the medulla. So this is midbrain. So this has to be superior cerebellar peduncle. This is substantia nigra. Now this part is divided into 3 sections. The medialmost section is for the facial nucleus, facial nerve nucleus, and then this is the corticospinal tract. Just remember what is necessary. Don't remember the rest of it, which is not important for the brainstem syndromes at least. Then what is this? Okay, superior cerebral peduncle, obviously. Then there is this nucleus. I'm gonna draw it with green. This is third nerve nucleus. You remember, right? The nucleus chart. Third and fourth, then actually it's 1 to 4, but since optic and olfactory are basically intracranial nerves, the optic nerve goes to the optic canal, and this thing olfactory nerve goes to the cribriform plate. Okay, so 1 and 4, so we remove 1 and 4, so it's basically only 3 and 4. 7, 5, 6, 7, 8, 9, 10, 11, 12. These are the nucleus which goes to the midbrain, pons and medulla. Just remember this. I'm going to erase this. Not important right now. And also we have this one structure. I'm going to draw it with red because its name is in red. So this is the red nucleus. Now if you know this thing, what is red nucleus? It basically red nucleus then relays into the cerebellum only. Its main function is to prevent ataxia. Alright. Okay, so this is it. This is all you have to remember from the midbrain to know the syndromes. Okay, so I'm gonna draw the syndromes with blue, so it gets easy for you. Okay, oh, I forgot to draw the nerve. That's wrong. Okay, so this is the third nerve. Okay, so let's do the syndromes. First is the North Nagle syndrome. North Nagle syndrome involves only this part of the cerebellum. Now, this part of the cerebellum, Nagle, North Nagle syndrome. Okay, cause ataxia of the same side, ipsilateral ataxia. What is third nerve? Third nerve nucleus is involved. So third nerve palsy. Third nerve supplies the ocular muscles. Okay. This if this is involved, only this part is involved. Like the third. Okay. So in Claudius syndrome, what is involved? Uh, red nucleus. But we know that red nucleus then crosses again and relies into the cerebellar this thing uh, cerebellum, so it causes ipsilateral sorry contralateral ataxia. I'm really sorry. First is red nucleus involvement causes contralateral ataxia, and third nerve palsy. This is it. This is all you have to remember about Claudius syndrome. Now, the third syndrome is basically this. Okay. Now, this is called as Weber's syndrome. Okay. This is called as Weber's syndrome. Now, what all is involved? Corticospinal tract is involved. We know that corticospinal tract, it decussates below the medulla, so contralateral part will be involved. So contralateral weakness. Alright. Then facial nucleus is involved. So it will be a upper motor neuron type of facial palsy, and it will be ipsilateral. Now, what is involved next? Third nerve nucleus, third nerve palsy. That's it. This is all you have to remember about Weber's. Now, we said 4 syndromes. So basically, there is this fourth syndrome which is called as Benedict's syndrome. Alright. Now, Benedict's syndrome is basically, it's a combination of this and this. It's a Weber's plus Claude. So what will we see? Will be red nucleus involvement will lead to contralateral ataxia. Just copy the things which we've written. Third nucleus palsy, which is common in both, and then corticospinal tract leads to contralateral weakness. Alright, contralateral weakness. Then facial nucleus will involvement will lead to Ullmann type of ipsilateral facial palsy. Alright, so this is it. This is about the midbrain syndromes. Midbrain syndrome. Let me check if the video is going fine. It is. So the next is Pons. Now it's gonna be really easy. Now the syndromes are really easy. The most complicated, I feel, according to me, is the midbrain. But let's see. Okay. So I'm gonna draw Pons. Pons ka shape is a little weird. You draw it like this, basically. Okay. So you draw it like this. Now what you have to do is basically, don't imagine what it is. Just keep drawing this, draw. Sorry, I'm gonna draw it with green. And then it's very simple. I'm gonna name everything. This is corticospinal tract. This is medial longitudinal sorry, this is medial lemniscus. This is medial longitudinal fasciculus. This, the one which is medial, is 7th. This is 6th. Why am I so messy? Okay, so this is 7th. The medial one is 7th. The lateral one is 6th. This is spinal lemniscus. And this is obviously middle cerebellar peduncle. This is it. This is all you have to remember. Also, you need to know that anatomically it's really important that this is the 7th nerve nucleus. 7th nerve nucleus winds around the 6th one and then it comes down, and 6th nerve nucleus just comes down like that. That is why the name of the 6th nerve is abducens, because the 7th nerve abduces around it. And again, okay. Also, 7th nerve is important because it holds, its branches actually hold 2 of the ganglion, right? Pterygopalatine and submandibular. So yeah, parasympathetic ganglion. So this is that. So let's start with the syndromes. We said there are 3 syndromes in this thing. The first one is really simple. You just involve this part. Always involve the lateral 2 structures first and call it a syndrome. This is called as Marie-Fox syndrome. Marie-Fox syndrome. Okay. Marie-Fox syndrome. It involves 2 structures: MCP, that is medial cerebellar peduncle, and spinal lemniscus. Now, spinal lemniscus is for this thing, so spinothalamic tract. So, medial cerebellar obviously will lead to ipsilateral ataxia, and spinal lemniscus, which involve contralateral spinothalamic tract. Now, spinothalamic tract is for pain, temperature, crude touch. Okay, pain, temperature, crude touch is for spinothalamic tract. So this will be gone. This is Marie-Fox syndrome. Secondly, we'll draw a syndrome which involves this, and this. So these structures are involved. We call it a syndrome called as Miller-Guebler syndrome. I don't know there are 2 B's or not, but it's called as Miller-Guebler syndrome. Okay, so as we can see, corticospinal tract involvement lead to contralateral weakness. Okay, now this is important. We said the 7th nerve and 6th nerve involvement, and 7th nerve involvement will be lead to palsy. Okay, but this palsy will be of element type. Right? Upper motor neuron palsy involves only the lower half of the brain. Matlab, if this side of the facial nerve is involved, it will lead to palsy only of the lower quadrant in UMN, and in LMN it leads to entire this side ka palsy, entire face ka palsy in LMN. So LMN is more severe than UMN in this case. So also 6th nerve palsy, right? LR6SO4. LR6 is lateral rectus palsy. So lateral rectus of that particular side, ipsilateral latus palsy, will be absent. Okay. And then this thing. What all? Okay, that's all. So this is Miller-Guebler syndrome. This is one more syndrome, and it involves involvement of this entire thing. I'm gonna erase this. Involvement of the entire thing. Now this is called as Fovley's syndrome. I don't know if I'm writing the spelling right, but it's right. So what all will be involved? We'll start from the first. 7th nerve, again element, ipsilateral palsy. 6th nerve, again element type of ipsilateral palsy. Then comes what? This is NLF. MLF is basically medial longitudinal fasciculus, and it leads to internuclear ophthalmoplegia. Internuclear ophthalmoplegia. It's very important. MLF, we call it MLF syndrome. Basically, in this convergence is positive, but there is gaze preference, if you know what I mean. MLF is basically, third nerve is connected to the sixth nerve via MLF. So uh, the visual pathway, man, I hate to go into the details, but this is how it goes. Area number 8, if you remember, is in the frontal lobe. Area number 8 of this side and area number 8 of this side. Okay, area number 8 on this side. So this is say for example left, and this is right. So left side area number 8 will give fibers to PPRF of the right side, and this PPRF will give the fibers to third nerve of the opposite and the sixth nerve of the same side. Okay, so sixth nerve of the same side. So third nerve is basically, if you draw the eyeball like this, and this is this, and this is this. So this is medial rectus. This supplies this, and obviously this is sixth nerve. Sixth nerve will supply lateral rectus. This is lateral rectus, so this will supply this, and this is medial rectus. So what will happen is, I'm going to draw this with different colors so that you understand. Also here we have a PPRF. So what happens is, usually impulse goes from area number 8, it via PPRF, it stimulates the lateral rectus, and via third nerve it stimulates the medial rectus. If these two are stimulated, the patient will look at the right side. This is basically called as medial longitudinal fasciculus. So if this is gone, so the patient only this eye can look towards the left, but this eye cannot look towards the left. But if you tell the patient to look in the middle, that converge the eyeball towards the middle, the third nerve is working, only this part is not working. So the patient will converge his eye, because this third nerve is the normal only. This third nerve is normal. Also this third nerve is normal, but the fasciculus isn't working. So the convergence will be positive, but he simultaneously cannot look towards this thing. Also, you should remember that in area number 8 there is again ipsilateral gaze preference. So if he cannot look towards this, so he will only look towards, he will be able to look towards it, and he will prefer this gaze. So there is ipsilateral gaze preference in frontal lobe lesions. Boy, I get so... Okay, so these are the 3 syndromes of, sorry, if I'm done or not. MLF is called obviously internuclear ophthalmoplegia. Now medial lemniscus. Medial lemniscus is basically for, tell me, come on. Posterior column loss. The posterior column is responsible for like fine touch, vibration and proprioception. Okay, fine touch, vibration and proprioception. Alright, now obviously corticospinal tract, contralateral weakness. That's it. This is all you need to know about the brainstem syndromes from midbrain and pons. Now we'll move on to the next brainstem syndromes. This is really important. Also, I'm gonna show you the arterial supply of, what supplies what. Okay, so we'll go to, we're done with midbrain, we're done with pons. Now we have medulla. Okay. Fuck, I'm proud of it. What is this? Inferior cerebellar peduncle. Now you know what, you have to draw midline so that it gets easy for you to understand what is what. So, like I told you, the eighth nerve nucleus will be in the pons, but actually it is basically at the junction of pons and this thing, pons and medulla. Okay, so here it is eighth nerve nucleus. All right, and I'm gonna draw the. This is fifth nerve nucleus, and this is 12th nerve nucleus. Alright, this is 12th nerve nucleus. Now, this is basically spinal lemniscus. This is one nucleus called as nucleus ambiguous, and this is important sympathetic trunk. Symp. I'm gonna write as symp. Okay, and obviously this is medial lemniscus, and this is corticospinal tract. Okay, and corticospinal discus is after this. Okay, so there are only two syndromes in this portion, and it's very simple. If this part is involved, and if this part is involved. Okay, so this is in the medial side, so it is called as medial medullary syndrome. Okay, so medial medullary syndrome, only three structures are involved. Tell me what it is. Corticospinal, obviously, contralateral weakness. Medial lemniscus will lead to what? Medial lemniscus holds the come on, medial lemniscus will hold the posterior column, but medial lemniscus posterior column of the contralateral side, contralateral posterior column loss. Then 11th nerve nucleus, 12th nerve palsy, 12th nerve nucleus is palsy. Okay, now remember this, that there is a rule of 17, that you divide this in 12 and 5. So in this lesion, the deviation of the tongue, tip of the tongue, will be towards, okay, and in 10th and 7th it will be away. The lesion, towards the lesion and away from the lesion. It's called as rule of 17. So that's one trick to remember. So deviation towards, this is medial medullary syndrome. Its second name is important. There are two syndromes. One is Gerine-Rousey and this is Gerine. So this is Gerine syndrome. Alright, okay, this is basically this is lateral medullary syndrome. What all is gone? 8th nerve is gone. What did I go? Spinal lemniscus is gone. Contralateral spinothalamic loss. My 5th nerve nucleus is gone. Now 5th nerve nucleus is gone, so the sensation over cornea and face will be gone. Now next is nucleus ambiguous. It will lead to dysphagia, and then we have sympathetic trunk. Sympathetic trunk loss will obviously lead to Horner's syndrome. Okay, so these were also, this is lateral medullary syndrome, is also called as Wallenberg syndrome. Okay, Wallenberg syndrome. So this is that, and these were all the syndromes. Now what's really important in this case is, the blood supply, and what will happen if the blood to that part is cut off, which syndrome, which arterial loss or which arterial block will lead to what syndrome. Okay, and I've tried to simplify it in a diagram. So you draw a box, draw midline, divide it in as usual. We did the same thing for nucleus, but we're gonna do it for syndromes now. This is obviously midbrain, this is pons, and this is medulla. Alright, so I'm gonna draw blood supply. We all know what artery comes from what. The vertebral artery comes from both the sides. Alright, and it'll give branch here, will give a branch here. It will continue, vertebral artery will continue at basilar artery. Now basilar artery will divide into simple PCA. This is PCA. Alright, PCA, basilar artery will, this thing will give the branches. This is basilar artery. This is pica, and also it will give a branch which is ASA, anterior spinal artery. Pica and anterior spinal artery. Pica is posterior inferior cerebral artery, ASA is anterior spinal artery, basilar and posterior cerebral artery. Okay, so this one is the P1 and this is the P2 segment. Okay, simple. So whatever the syndromes in the midbrain, syndromes will happen, any syndrome, all the 4 syndromes will happen due to P1 block, PCA. Midbrain syndromes, I'll write it more clear. Midbrain syndromes will, because of PCA, Pons syndromes. What are the midbrain syndromes? Come on, let's revise. North-Nagel, Claude's, Weber's, Benedict's. Now these are the Pons syndromes. Pons syndromes were 3. What were those? Miller-Gubler, Fovili's, and Marie-Fox. So these are because of basilar artery. And now these are the questions they ask most commonly. So this is basically, what is this? This is the medial part of the medulla. So medial medullary is because of anterior spinal artery, and lateral medullary is because of, actually it's because of vertebral artery, but also if vertebral artery is not an option, the answer is pica. So this is one way to remember all the brainstem syndromes, and it's very simple.